Good morning. I'm just waiting. There's three different presentations, so they have to load them separately onto the computer. So it's just taking a second before we begin. Dr. Achman, may I begin yet? I can start? Thank you. Well, good morning, and thank you for being here this morning. Thank you also for inviting me and allowing me to be part of your hospital for the past 2 weeks. I am deeply honored and very impressed by what I've seen and what I participated in. I met with Dr. Alla yesterday and Dr. Sharif, and at those times I expressed that the issues, the controversies, the management problems that you see here are identical to the problems I see at home. And so in many ways I feel we're two institutions just happen to be separated by a really big ocean. But I really do thank you. It has been a pleasure to meet different people, to have tours of the hospital, to hear about the patients, to meet some of the patients, and to meet all of you as well. So thank you. This morning I've broken this into 3 sessions. All are very short, so and will be available on the website, as Dr. Sharif had said a few days earlier. The first one, we're going to critically appraise an article and really look at applicability. Secondly, and just look at applicability and look at the situation where you can't find any evidence. Secondly, we'll just play a quick game show. I don't know if you have the TV show here called Jeopardy. It's a North American TV show from the US, and it's hosted by a Canadian, so that's why the Canadians watch it. And essentially, as I'll reinforce this as we go through, what happens in Jeopardy is that you are given the answer, but you need to say the answer as a question. So if somebody said the largest children's hospital for cancer in Egypt, the answer would be, what is Children's Hospital of Egypt? That's how you would do it. So you'd have to give it as the answer as a question. It's been a long-running TV show, so we're going to play a short game of that, and then I would just like to summarize some of the things that we've accomplished. So firstly, we're going to look at a systematic review, again, just to reinforce the techniques that you've gone through. And this is unfortunately for me the last time today, so that you'll be able to critically appraise a systematic review, and we'll complete a knowledge test about that. I just would like to review with you one more time that we've gone through different steps of evidence-based medicine over the past 2 weeks. The very first day, and we've been reinforcing this as we've gone through each of the sessions, each of the 8 different sessions, that you need to form a really good question. And those are questions that, sometimes to answer your knowledge, they are background questions. Who, what, where, when, why, and how. And we use those a lot when we're trying to find out new information about new diseases we don't know or new diagnostic tests. Foreground questions are questions when we're trying to find out information that will help our patients. And we use the PICOS model: the patient, the problem, the population being addressed, the intervention, the comparison intervention, the outcome, and the study type. And we had an episode, we've reinforced that each of the sessions that we've gone through. Then the next step is finding the evidence. And we said there were 2 different types of evidence. There's quality filter evidence, And then there's, and those are things such as TRIP database, clinical evidence, Google Scholar, Cochrane database. And then there's search engines which will help you find quality, such as PubMed clinical queries. And I was talking to one of the physicians here yesterday, and one of the things that I didn't have an opportunity to remind you, that in the top right-hand corner of PubMed, no matter what page you're on, there's something called My NCBI. And there you can join free. It doesn't cost you anything. And the search, you can save your searches. So that if you're searching at work and you quickly want to save because you have to go off and resuscitate somebody, you just click the save button. And then you can go at home when you're at home and you can access that saved document. And that search is available for you. It's stored on a central search engine, central computer somewhere, I don't know where, but it allows you to search different things at different places and use that search over and over again if you're looking for the literature. So that if every month you wanted to review osteosarcoma, you would just click the search again and it would update your previous search. It's very helpful, especially if you have a very complex search that you've taken a little while to put together, that you may want to keep because you want to research more in. I keep I'm a generalist in pediatric oncology, but my areas of interest are osteo and Ewing's and rhabdo. So I have 3 different searches there, and about once a month or every other month, I just go in and click on and see what's new out there. So it's a very helpful technique to use. Then we went through the 3rd step of evidence-based medicine, looking at validity of therapy articles, and we reinforced the concept of randomization, intention to treat analysis, and the idea of blinding or allocation concealment. And then we practiced on reading a few articles there and went to a systematic review. We said the validity of a systematic review is slightly different. You have to look at the steps of evidence-based medicine. So what's the question? What's the literature search? What's the quality of articles? And specifically, one of the things we're always concerned about, publication bias in a systematic review. And then we concentrated on the concept of heterogeneity and why all the studies need to be similar to combine them and why we want a p-value that is closer to 1. So today I'd like to go through a clinical case scenario, quickly work with you appraising that systematic review, talk about application, and then doing an evidence-based medicine game. So a physician was on an airplane flight from Frankfurt to Cairo, and as he gazed out of the window of the plane, it was over the Mediterranean Sea, he was suddenly struck by the idea, what if he had to evacuate the plane in the parachute? And really, was there any evidence out there that parachutes actually worked? So he did a search, and he said, among pediatric oncologists on a flight from Frankfurt to Cairo, does a parachute versus no parachute lead to increased survival? And I thought that the best way would find that would be a systematic review, because that would be the best or the top type of evidence. I converted those in. I went to PubMed, and on the left-hand side of PubMed, you can select MESH headings, medical subject headings, and I thought, well, you're in an airplane, so it should be an airplane accident or an airplane death. So that actually mapped to aviation accidents. And parachutes actually mapped to protective devices. I pumped those into PubMed, and I got 102 articles, of which the 4th one was Parachute Use to Prevent Death and Major Trauma Related to Gravitational Challenge, a systematic review of randomized control trials by Dr. Smith. And that's the article you have with you. We can actually find most of the information because it is a structured abstract right in the abstract of the article. And so just to answer the 4 different questions as we go through to assess the validity of this article, the first question, did the review explicitly address a sensible clinical question? And if you look in the article, it's quite clearly stated in the objectives to determine whether parachutes are effective in preventing major trauma related to gravitational challenge. So the question's there. It's succinct. It's tight. It would be an interesting outcome for us. So the next thing I want to know: did they do an exhaustive and complete search? Well, they said within the body of the article that they searched for randomized controlled trials, which we have talked about are really good evidence. They did use they used Medline, they used Web of Science, which is another database that sort of cross-links with Medline and basic science research. They used the Elsevier database called Embase, remembering that about 60% of articles, 40% of articles will be found in only one. They went to the Cochrane Library, so a really good site. They looked at internet sites, and they looked at citation lists, and the words they used were parachute and trial. They wanted to be as broad as possible, so they didn't look for any language restrictions, and they included any studies that entailed jumping from a height greater than 100 meters. And they accepted that the intervention was going to be some sort of fabric device, usually called a parachute, secured by strings to a harness, and during a free fall with the purpose of limiting the rate of descent. And they excluded studies that were not randomized. So it sounds pretty good, like they were looking for the literature search. They were pretty broad and specific. So, quality of the articles. So they completed this search, and I tried it again last night. And our search strategy did not find any randomized controlled trials of a parachute. So we've got a really good research question. We've got a really good literature search. They've been very broad, but there's nothing out there. So what are we going to do? Well, we can't even assess the reproducibility. We can assess the reproducibility of this study here, as I did last night, but we're stuck with what should we do? Because we can't say that there's any results that we can analyze. We can't assess similarity or heterogeneity. There's no overall results, and there's no precision of those results because there's no results. Now, they did, in their article, say, they did give some, and this is a BMJ format that's helpful for quickly scanning articles. They said parachutes are widely used to prevent death and major injury from gravitational challenge, that the use is associated with adverse effects due to failure of the intervention, and studies of free fall do not show 100% mortality, and they actually have a reference for that in the article. I think it's reference number 4. What this study adds is that they couldn't find any RCTs. The basis for parachute use is purely observational, and its apparent efficacy could potentially be explained by a healthy cohort effect. And what they mean by that is only healthy people, fit people are using using parachutes, because if you're terribly sick, you're not going to be able to use the parachute very well. And then they said individuals who insist that all interventions need to be validated by an RCT need to come down to earth with a bump. So it was done as a fun document, but the idea is when you're searching, and this is the absurd situation, but when you're searching for information, you're not always going to find evidence out there that's relevant. And people have done work, and the nice thing about a systematic review is that you know somebody has done a search to show there's no evidence. Now, it's totally absurd in this situation because observationally we know if I was going to jump out of an airplane, I'm going to make sure I have a parachute on because my colleagues who I've observed at jumping always had a parachute, and they did much better than I could even suppose people jumping without a parachute. So some of the situations are absurd, but the situation is that many times you're not going to be able to find a lot of evidence, or you're going to find evidence you're going to find evidence that doesn't jive. And that's where evidence-based medicine uses patient preferences, physician preferences, and physician values to incorporate in the management of your patients. The evidence may be very strong, and you'd hopefully be swayed by stronger evidence, but in a lot of situations you're going to have only weak evidence, and you're going to have to make a decision. And people are going to say, well, evidence-based medicine hasn't helped you. Well, it actually has helped you because you have formulated a question, you have searched for the information, and unfortunately there's no information out there. Hopefully that will spur other people on to develop research, and hopefully that's one of the things that I've left with you here, is to keep asking questions, and when you don't find an answer, start to think about how could you design an experiment, how could you design a study, how could you detail what you're observing in that situation. So what I'd like to do now is play Jeopardy. I'll just post the rules first so you know. So in Jeopardy you pick a category. The categories, when you'll see it, will have a point value, and then you get an answer and you have to formulate it as a question. And if you tell us the correct question, you'll win the points that are there. So we're going to play single Jeopardy. And I guess you can't hear that from the...
Good scores from each of our contestants. Let's get to work now in Double Jeopardy. See how well they fare in this round with the 2 daily doubles to help them add to their winnings quickly in these categories. Let's take a look. What do we have? We've got work.
Okay. So now I got to figure out how to shut that off. Okay. So the headings are questions, study design, searching for the evidence, validity, and results. Would somebody like to start? Okay, so we'll do question 1. So the question is, these kinds of questions ask for specific knowledge about issues related to managing a patient with a disorder. The question? Anybody? So I've lost my mouse. Oh, there we go. So you've heard this, and the answer are what are foreground questions? Remembering that a foreground question is helping you manage care about a patient. So we've done 100. Does anybody want to? I'll go to the second 100, and the person who answers that question can then choose. The 4 most common types of well-built clinical questions that are asked. Okay. Okay, what are PICOs? Anybody else? Okay, I'm just losing my mouse again. Actually, these are the domains of the questions. PICOs is the format, but you're right. These are the domains. These are the therapy, the type of study, the diagnosis, etiology, harm, and prognosis. I'll ask you to choose a question for the next. Yeah, anyone. I just got to get my mouse back here. Study design for 100? So, a study design that involves an intervention, an investigator-controlled maneuver, such as a drug, a procedure, or treatment, and investigates the effect of the intervention has on the study subjects. The answer? What's in a controlled study? An experimental randomized trial, so that's correct. So you get 100 points. You get to also choose the next question. Study design for 200. This study design attempts to obtain greater statistical power than could be achieved by individual small studies. Anybody? What's meta-analysis? Let's see if that's correct. What is meta-analysis or systematic review? Bonus, you got 200 points. Next. Which question would you like? You can be searching for evidence for 100 points. A collection of databases focusing on clinical trials and systematic reviews. I heard somebody say, what's the Cochrane? Let's see if that's the right answer. And you're right, so you get 100 points. Next question you like? Dr. Samira? Results for just 100? You don't want 500? Okay. The proportional reduction in rates of harmful outcomes between experimental and control participants. It is calculated by dividing the rate of harmful outcome in a control group minus the rate of harmful outcome in the experimental group by the rate of the harmful outcome in the control group. CER minus EER over CER, used with a beneficial exposure or intervention. What is relative risk reduction? Bingo. So you get to choose the next one. Results 200. So you're sticking with results because you feel comfortable there? Okay. The absolute arithmetic difference, risk difference in rates of harmful outcomes between experimental and control groups, calculated as a rate of harmful outcome in the control group minus the rate of harmful outcome in the experimental group, CER minus EER, and the use is restricted to a beneficial exposure or intervention. Sorry? Okay, so we've got 2 answers. Let's see, they're both the same. What is absolute risk reduction? Good. So who wants to choose of you 2 for the next? Okay. Dr. Samira, you've been volunteered. Dr. Samira? Oh, you're not going to be adventurous and just go for 500? The probability that results as or more extreme than those observed would occur if the null hypothesis were true and the experiment were repeated over and over. A value of less than 0.05 means that there is a less than 1 in 20 probability of a result occurring by chance alone if the null hypothesis were true. P-value I heard back here. What p-values? So let's check that. Yes. Okay. I'm going to go back to... Oh, come on. You don't want to go for 500. Range between two values within which it is probable that a true value lies for the whole population of patients from which the study patients were selected. It's a range. What's the confidence interval? Let's see. I heard that answer first. See if you're right. Yes, what's the confidence interval for 400? Oh, 500 finally. The number of patients who need to be treated over a specific period of time to achieve one additional good outcome. It is the inverse of the absolute risk ratio, 1 over AR. When discussing it, it's important to specify the intervention, its duration, and the good outcome. Number needed to treat, I heard from, I think Dr. Samira was quick off the gun there. Yes, right. Okay. Dr. Samira? Study design 300. Case series control, case control, cross-sectional and cohort studies. So the answer that's been chosen is what is observational studies? Good point. 300 points for that. Study design for 400. Differences in results of individual studies included in a systematic review. What's the, I heard, sorry, forest plot or heterogeneity? Yeah. So that was Dr. Sonia, I think? Oh, sorry. Okay. What is heterogeneity? Good, so you get to choose the next. 500 study design? Okay. Answer, a 5-point score used to assess the quality of RCTs included in a systematic review. It is named after a Colombian gentleman. A Haddad score. This is the first answer off the mark. Let's see if they're right. That's the Haddad score, 500 points. Sorry, who answered here? I missed. Okay. So questions for 300. Patient or problem, intervention, comparison, outcome, and study type. I heard it down here. PICO? Good. PICOs. So, who said PICOs? Questions for 400. The 5 steps of the EBM cycle. How about the first 3 steps of EBM cycle? Question, literature review, anybody got the last one? And critical appraisal will be the third one. That's what we've done. So I'm going to throw it out to the top. Up there, does somebody want to choose a point? Searching for evidence 200. Search strategies designed to retrieve high-quality evidence from published studies. Let's see, systematic. What's a systematic review? What are the EBM filters or clinical queries? Remember, we were talking about the search. I'll give it to you anyways, because I'm in a generous mood. What question would you like next? Searching for evidence, 300. On average, 1 inch of rain is equivalent to how many inches of snow? This is a Canadian question. Anybody? Even a guess? So 1 inch of rain is equivalent to 1 inch of snow? Actually, it's about 10. Sorry, I know that's not evidence-based medicine. Pardon? Well, 1 inch of water would equal 10 inches of snow. Oh, I did? Okay, I can't go back, sorry. I guess I get deducted points for that. And I'll let you ask the next question. Searching for evidence, here's the mouse. Occurs when the publication of research depends on the direction of the study results and whether they are statistically significant. So Dr. Samir says publication bias. Is she right? Yes. Dr. Samir? For questions for 500. The conscientious, explicit, and judicious use of the current best evidence in making decisions about the care of individual practice. Evidence-based clinical practice requires integration of individual clinical expertise and patient preferences with the best available external clinical evidence from systematic research and the consideration of available resources. What is evidence-based medicine? Yes, that is the answer. So we have validity. Nobody really wants, is that too much statistics or something? Does anybody want 500 searching for the evidence? And then we'll do validity? Okay, let's do that. A medical search engine with emphasis on evidence-based medicine and clinical guidelines and queries, including content from Cochrane and Bandelier. Don't fall over it. What's the TRIP database? And we'll go to validity. Want to start at the bottom and work up? 500. A systematic error in design, conduct, or interpretation of a study that may cause a systematic deviation from the underlying truth. Right. What is bias? 400? We'll just go up the list. A form of measurement bias that occurs when patients whose status on the outcome or endpoint of interest is unknown. Remember the critical appraisal worksheet? Close. Just down the worksheet a tiny bit. Just one question below those. Pardon? So what is follow-up? It's the question where you don't know what's happened to people, and we had to make sure that we kept as many people in the study from the beginning. 300. Patients, clinicians, those who monitor outcomes, judicial assessors of outcomes, data analysis, and those writing the paper are unaware of which patients have been assigned to the experimental or control group. And I heard the answer. If you I heard sort of parts of it, but this is actually the quality step we're looking at when we use the worksheet. Good. Blinding. And for 200, analyzing study participant outcomes based on the group to which they were randomized, even, I heard it already, intention to treat. So I do want you to remember that as you go through. So just the intention to treat analysis is important. And the very last one, the very last question, validity for 100 points, when putting individuals into groups by chance, usually done with the aid of a table of random numbers. And bonus, yeah, what's randomization or random allocation? And we're finished that. So I'd just like to take a second and summarize again where we are. I just want to quickly walk through what you've accomplished to remind you that you can do evidence-based medicine, and you have done it for the past 2 weeks, and encourage you forward into the future at this hospital. So there's some really good quotes out there. Don't confuse me with the facts. My mind's already made up. I wouldn't believe this even if it were true. And the essence of wisdom is the ability to make the right decision on the basis of inadequate evidence. Alan Gregg is actually one of our big pollsters that the government uses to find out if they're thinking the right way. But really these are statements that you're going to have to deal with any time that you say that you're using evidence-based medicine. There is some resistance out there, and you've probably felt it at different times, and you may still have some here, and that's okay. But if you can walk away from here and ask questions, then you're miles ahead of where we started 2 weeks ago. So we went through it, and just quickly, we went through background questions that they were composed of 2 parts, and then we looked at foreground questions and PICOs. Then we went through finding the evidence, we looked at PubMed clinical queries, and then these are 4 really good examples of quality filtered literature sources. As I think several people have tried TRIP database, it's quite useful. As you saw, it also gives you the access to e-textbooks right off the site. So it saves you time searching and it gets you where you need to go. And you can also use Medline because it's built right into it. And it's free. Then we went through validity and results, and we calculated and we played with relative risk reductions, absolute risk reductions, and we talked about number needed to treat. We did systematic review, and we looked at heterogeneity and p-values. Well, what are you capable of doing? You've shown me over the past 2 weeks that you're very capable of composing well-built clinical questions using PICOS. From talking to several of you and different situations, it's quite clear that people are starting to feel comfortable using quality filtered literature sources, such as through the TRIP database. I showed you that using a worksheet in critical appraisal is quite simple and a stepwise approach to assessing the clinical health literature, and that answering clinical questions that are important to you and your patients is what will motivate you to be evidence-based. In the future, unfortunately, it's the tip of the iceberg. We've only covered a very small part of evidence-based medicine. But you've covered 2 of the 5 steps quite comfortably, and you're starting into critical appraisal of articles. So really, to build a children's hospital that uses evidence-based medicine to have the best practice for all our children. It'll benefit your children here. It will benefit children around the world as you start to publish information. It will benefit the children that I care for in northern Alberta. So having pediatric oncologists who are evidence-based is the real goal, because that's why we're all doing it, is for the children, be they children in Egypt or children in Canada. That's why we do evidence-based medicine, because we want the best practices possible. And hopefully, if you use this, you'll be perceived and then knowledgeably known to be a leader in child health in Egypt, if not Africa, if not the Middle East, and if not the world. I don't know, I use Google Translator. I don't know if that says exactly what I said in English, but Google Translator, I didn't check the evidence of how good it is, but I just wish you all the best in your journey of evidence-based medicine. And I thank you so much for inviting me and letting me be part of your hospital for 2 weeks.